don't know how powerful your voice is. They don't want to hear another legislator. They don't want to hear somebody else that's advocating. Sometimes they just want to hear that personal story.
Prevention is done with regard to asbestos by stopping all use.
Very tiny doses of asbestos can cause malignant mesothelioma.
The only way to stop asbestos-related cancers is to ban it.
About 70 other countries have asbestos bans. The U.S. still doesn't.
This isn't right. Don't let this happen to other families. It can be prevented.
About 40,000 Americans die every year of asbestos-caused diseases.
Good morning, Stephen Markowitz. I have the pleasure of moderating this session, which means keeping these extremely knowledgeable and loquacious speakers on time. So we'll see how that goes. But I know that I want to say one thing just briefly, and I will do short introductions of each of the speaker because I feel like our self-introductions before didn't quite do them complete service. But last year I went to, as did Perry and Linda, to the International Mesothelioma meeting in France a year plus ago. And I have to say I left that meeting quite hopeful about mesothelioma, not because there were any breakthroughs announced in treatment. It's mostly about treatment, advances in diagnosis, almost nothing about asbestos or prevention, but that's okay for that meeting. What I was hopeful about was there were 500 people there, actually, who are working on mesothelioma, who are working on finding cures for mesothelioma. And I would say at least half of them were under age 40. Very smart people. And so, again, no breakthroughs announced at that time, and maybe Dr. Wolf can let us know if there's been anything since that time. But I left hopeful because there were so many people who care about this disease, who are finding cures for this disease, and including young people, and that we will continue to make advances in the future. Our first speaker is Rachel Duran, who introduced herself briefly before, but I'm going to say that she is a commercial officer of the Department of Commerce who apparently spends a lot of time in other countries helping the U.S. in commercial business. She has her 2 master's degree, 1 master's in business admin, MBA from Virginia Polytech, an additional master's in international commerce and policy from George Mason. So welcome, Rachel.
Thank you for being here, and thank you, Linda, for pulling this together today. We really, really appreciate it. Today I am also joined by my mother, who was a special education teacher for years, and so she's going to begin the presentation for us.
Good morning, everyone. Again, thank you, Linda, for giving us the privilege to share the story of my husband and relating his cancer journey. This is my family. This was taken in Hawaii. Gilbert and I met at the age of 14 and 15. He was my first date, and I was his first date. We grew up together, and when I graduated high school, I went on to college. He went to the Marines. And after he got out of the Marines and I graduated, we got married and we had our 3 kids. Dominic, our son, is in the middle. Unfortunately, at the age 30, he had a tumor in his liver and he left us. Then we have Alicia, who's a civil engineer, and then you all met Rachel. Gilbert was a devoted husband for 47 years. He was a dedicated father and grandfather. He loved his granddaughter, and she said he was his best family friend. He worked for the Garney Construction for 39 years, and we're thinking that that's where he was exposed to asbestos. He was a brilliant industry leader. He was a father figure to many. When I retired from teaching, I worked with the company for 9 years also, and the guys would call him Daddy Gil, and me, Mama Alice, because we were there for our kids, and in any way that we helped him, that we could help him, we helped him in the crew. He was the highest money maker for the company, $1 million jobs. Other crews would come and look at his jobs because they knew he was performing to the best that they knew. I mean, he was just a hard worker. If things needed to be done, he'd get in there with the trenches with the guys. He started off as a laborer, and that's where we believe he was exposed to transite pipe, AC pipe. And then he went on to a foreman, and then he ended up as a superintendent. He was a generous, kind individual who helped many people in need. Again, these are many ways that we think he may have been exposed to asbestos. We all used to use foot powder, talcs, baby powder. We put baby powder on our kids not knowing that we were putting asbestos on their diapers. You know, it was a sad situation, so many exposures that we all were exposed to. Why he got the meso and not us, I don't know. Brakes was another thing he always worked on. He worked with heavy equipment. He used to help his dad change brakes. So it was just things that he was always exposed to. The main thing, like I said, was the transite pipe. They were cutting it in the trenches. And I was thinking about Dr. Lemon, you know, all that powder going all around us. I talked to some of his fellow employees, and they remember the dust they were also working in. At that time, PPE was not even available, and we didn't know about the consequences that would be coming 20, 30, 40 years from now. His first diagnosis was, I love the outdoors, we both did, and we went hiking for Mother's Day up to the mountains. And unfortunately, he couldn't breathe, which was very, very different because all along he was a hiker. When we'd go hunting, he'd leave me in the dust. And, you know, that one summer, it was like, what was going on? He was constantly coughing. There was a lot of phlegm coming, and he says, it'll clear up, my lungs will clear up. And by August of 2020, that's when we got the diagnosis. We finally took him in, and he had 5 liters of fluid in his left lung, and his lung had collapsed. They drained the fluid, they sent it in, and that's when he was diagnosed. It was like a world had stopped. They gave him 6 months to live without treatment.
And when they gave him that diagnosis, he called us all up and he said, I have been diagnosed with mesothelioma. I have 6 months to live, or I'm willing to fight for you guys and go through treatment. He's like, I've lived my life, I'm ready to go, but for you guys, I will fight this battle to spend more time with you. And so the treatment began. In September 2020, we started with both alternative medicine and modern medicine. We've gone through chemotherapy, we tried radiation, as well as a list of alternative medicines. You have 3 powerful women looking after this person who is their center, and we could not get enough of Google searching every possible remedy that could exist. And I'd call him up and I'd say, Dad, how are you doing? He's like, I'm just a happy porcupine. They're poking me everywhere. But, you know, as we kept trying everything we could, we had regular chemotherapy, we had the alternative medicine, and then the cancer just kept spreading. It spread to his lymph nodes, his heart lining, his hip, upper back, ribs, and muscles. Every day there was a new ache. He was going under vitamin C, ozone therapy, supplements, mistletoe, CBD, electromagnetic field therapy, multiple rounds of radiation, blood transfusion. And so I would fly in from overseas and talking to doctors in Serbia, talking to doctors everywhere I went, just trying to find a solution. And in the end, you know, it just had this incredible physical toll on us. He couldn't breathe. He couldn't eat, he couldn't sleep, he was in constant pain. There was not enough opioids that could help him, and he hated every single one of them. He had 3 overdoses, and so we always had to have Narcan by standby. Slowly he had convulsions, memory loss, and we spent so many nights in the emergency room. He had extreme weight loss, muscle weakness, and chronic constipation. And the family was there by his side every time, and he was constantly concerned about us, about how we were holding up and how everything could be done. After 3 years, he was mentally and emotionally exhausted from the constant pain. And we watched him just slowly fight for his life, but knowing that it was just going to be difficult. This picture that you're looking at is my niece. She was 7 at the time, and that was Father's Day. And she was asking him for just a little bit more time with him so that he could be around for her. And up until the end, he still tried to make it easier for us, constantly saying, you know, I'll do what I can. I'm miserable right now, but we'll do what we can. On August 7th, he did ask to be put into hospice. And we checked him in on that Monday. And on August 11th, he passed away. However, when he went to hospice, it was because the pain was just intolerable, and he would fade, and then he would come back, and then he would fade. And when he would come back, he would tell us, certain messages. And one of the last times that he was cognizant, he just looked at us after a family of his coworkers came in with their family and their children, and he said, this isn't right. Don't let this happen to other families. It can be prevented. And that was about a Wednesday, and he died on a Friday, and so then we started Googling what we could do, and we found Linda. And in the darkness, we did find a ray of light, and all of you guys for helping us, because when you're at that low point, you're just looking for something that you can do to help others. And so since then, we are working with the company that he worked for all of those years to educate the workers, because we know that all of them have been exposed. And as they were coming to say their last goodbyes to hospice, we knew that there will be another family following us and going through this. And so we are so grateful for this organization and this opportunity to share the story with hopes that it will stop other families from having to go through this loss and having to experience this. And for those who are going through it, to know that they do have support when they need it, and to try to find some solutions and a positive out of this outcome. So thank you for your time, and we really appreciate being here.
We have our numbers, and we have our stories, and then we have Mr. Duran. So thank you very much, Alice and Rachel, for telling us about your father and your husband. Next, we are going to hear from Chris Oliver. Chris Oliver is now an associate professor at the Public Health School at the University of Toronto. Not that long ago, she was based in Boston, where she was an associate professor at Harvard Medical School, and really over decades focused on occupational diseases in general, but especially asbestos-related diseases, publishing over the past 40 years. I remember a particular article she wrote in the early 80s about school custodians and their risk for asbestos-related disease, but really a consummate clinician and public health researcher. So, Chris.
Thanks, Stephen. So I think on this, the 20th anniversary of the ADAO, it's appropriate that we go back to basics. So I'm going to start with Asbestos 101. So asbestos is a magnesium iron silicate fiber found naturally occurring in the Earth's surface. This is an example. This is a chrysotile mine in Asbestos, Quebec, in Canada, in Ontario, Canada. And at the time, the town was named Asbestos. It has now been renamed to the Valley of these Springs. Val de Source, I think, is the French name. There are two principal types of asbestos. They are serpentine and amphibole. Chrysotile, the serpentine fiber, accounts for over 95% of asbestos sold and used around the world, and also in the United States. It's often referred to as white asbestos. Amphibole fibers include amosite, crucidolite, actinolite, anthophyllite, and tremolite. These 6 commercial asbestos fibers are regulated by OSHA. Libby amphiboles are contained in vermiculite, which is mined in Libby, Montana. The amphiboles are tremolite, and the amphibole asbestiform fibers, winkite and richterite. This is a scanning electron micrograph of amosite asbestos, often referred to as brown asbestos. And you can see from this micrograph the physical characteristics of amosite asbestos. And if you'll note, they're rod-like, needle-like. In contradistinction to this is chrysotile asbestos. And you can see the physical characteristics of chrysotile here. It's curly. It's often referred to as curly asbestos. And you can see why chrysotile asbestos lent itself to being used in the manufacture of textiles. The uses of asbestos are TNTC, as they say, too numerous to count. They include textiles, boiler and pipe insulation, fireproofing, wallboard, plaster, cement, floor tiles, brake linings, roofing materials, gaskets, and of some note today is the asbestos that's used in the manufacture and used in the diaphragms used by the chlor-alkali industry to manufacture chlorine. And this is one of the uses that is under some contention right now. Asbestos has been used in home appliances like toasters and hair dryers. Asbestos contaminates vermiculite and talc. Non-malignant asbestos diseases are asbestosis and pleural disease. Pleural disease includes pleural plaques, which is circumscribed pleural thickening, diffuse pleural thickening, which is just what it says, and has been associated with death from respiratory failure. Round atelectasis is an interesting pleural abnormality related to asbestos, and it's an area of increased density on chest x-rays and CT scans that can resemble lung cancer and have been responsible for a number of unnecessary thoracotomies. Malignant asbestos-related diseases are lung cancer, ovarian cancer, cancer of the larynx, gastrointestinal cancer, and malignant mesothelioma. Lung cancer is the most common cause of cancer deaths worldwide. In 2019, it accounted for more than 20% of cancer deaths. Lung cancer is the most common occupational malignancy. Lung cancer is the most common asbestos-related malignancy. Asbestos and cigarette smoking act in a synergistic manner to increase risk for lung cancer over and above that of either of these two agents alone. Fortunately, I'm not sure if fortunately is the right word to use here, but we do have a method now for screening asbestos-exposed populations and other populations at risk for lung cancer. And it's low-dose chest CT scan screening, which has been shown to be associated with a 20% drop in lung cancer mortality in the U.S. And one of the references, I have reference number 2, is a great review of the topic in the form of a Collegium Ramazzini position statement, which was spearheaded by Dr. Markowitz and was just recently published, so you might want to take a look at that. Gastrointestinal cancer, over the years that I've been involved with occupational medicine, has been a contentious issue. As you may remember from a slide that Dr. Lemon showed, Irving Selikoff had data to support an increase in risk for gastrointestinal cancer due to asbestos exposure. And then over the years, it became somewhat controversial. But over the ensuing years, there's an abundance of literature that has been published that shows statistically significant associations between occupational exposure to asbestos and increased risk for esophageal, stomach, and colorectal cancer. One of the more recent publications published by the University of British Columbia is referenced at the bottom of this slide, and that was published in late 2023. It was a systematic review meta-analysis. Malignant mesothelioma is a sentinel event for asbestos exposure. The only other agent that has been shown to cause malignant mesothelioma, in my opinion, is erionite, which is also a mineral fiber found naturally occurring in the earth. In 2024, an article was published in the Journal of Cancer Research and Clinical Oncology that looked at what information do we have about asbestos exposure and malignant mesothelioma morbidity and mortality over the years 1990 to 2019. And the authors analyzed a bunch of data that came from the Global Burden of Disease program. And what was observed was that the age standardized mortality ratio between 1990 and 2019 decreased. It did drop. On the other hand, the number of cancer deaths, the number of deaths from malignant mesothelioma increased by 90% during that period of time. So if anybody is under the illusion that malignant mesothelioma is becoming a thing of the past, I think these data and other data that have been published continue to show increase in numbers of malignant mesothelioma deaths. Risk factors for disease are shown on this slide. Dose is an important risk factor. The higher the dose, the greater the risk for asbestos-related disease. However, there is no dose below which no risk for asbestos-related disease has been shown. For example, the dose-response relationship between asbestos and lung cancer is linear. There is no threshold, and no threshold has been shown for any other asbestos-related disease. And we do know, particularly with malignant mesothelioma, that there's increased risk at as little as 1 day of exposure. So very tiny doses of asbestos can cause malignant mesothelioma. Time since first exposure or latency, they're almost the same thing, has been shown to be a risk factor for malignant mesothelioma. And in 2019, an article was published by Loomis et al. That showed a linear dose-response relationship between time since first exposure to asbestos and risk for malignant mesothelioma. Smoking increases risk for lung cancer and laryngeal cancer, increased more together with asbestos exposure. Non-malignant asbestos-related disease on chest X-ray or CT scan connotes an increase in risk for subsequent development of lung cancer and malignant mesothelioma. Sex is not a risk factor for malignant mesothelioma. In 2015 and 2021, textbooks from the Blue Book series that is published by the World Health Organization stated that the population attributable fraction for malignant mesothelioma for asbestos was 80 to 90% in males, whereas in the US and France, for females, it was 20 to 40%, implying that the suggestion is that women are at less risk for malignant mesothelioma with asbestos exposure than men. And this is not true. And I'll refer you to, I think it's reference number 6. First author is Xavier Bauer, which was published in the last couple of years, which reviews this subject and shows very clearly that the risk for malignant mesothelioma in women is not that different from men. One of the major factors where there is a decreased risk is because inadequate occupational environmental histories were taken. So going forward, prevention has already been mentioned here. And I have to point out one thing on this slide that I'm embarrassed to say I didn't think about until Stephen gave his talk today. Screening is not secondary prevention. It's tertiary prevention. However, education has been mentioned here before. It is critically important in preventing asbestos-related disease. Elimination of exposure, we know, is critically important, and ADAO has been a major leader in trying to get an asbestos ban passed in the United States so that it can at least be favorably compared to the 69 other countries that have banned asbestos. Screening is a valuable tool for saving lives and for preventing worse outcome in patients whose lives cannot be saved. And we have screening for lung cancer, which I mentioned. Colonoscopy is a reasonably good screening tool for colorectal cancer. So with that, I hope I haven't run over my time too much. Thank you very much.
Okay, thank you. Thank you, Chris. That was a terrific summary. Great, and I think about 12 minutes, so that was great. Next is Henry Anderson, who also goes by Andy. He hails from the all-important state of Wisconsin, always important state, I should say, of Wisconsin. He's an occupational medicine physician. He was chief medical officer in Wisconsin for years, including in charge of occupational environmental epidemiology. But what I associate him most with is he was one of the first really to show epidemiologically that families of asbestos workers were at risk for asbestos-related disease, publishing that in the 1970s from his time at Mount Sinai. And that was very important to show that above and beyond the immediate risk that workers had to asbestos and developing fibrosis, scarring, and cancer, family members were also at risk. So let me turn it over to Andy.
Thanks, Steve. What I want to begin with is the asbestos triangle, and that is at the top of the triangle, there's a small group of people who were the miners that generated the products that we're concerned about now. But the real problem with asbestos is that it really was widely used. So you'll go down then to the processors, who are the factory workers. And if you think in terms of how we investigate environmental issues or occupational issues, we typically begin with the most heavily exposed individuals, who tend to be occupationally exposed individuals. So on the public health side, when we're looking for unusual diseases or sentinel diseases, we really look at what's going on in various industries. And as new industries come along, that's where we begin to do some surveillance to look at what kind of diseases are occurring. And as you move down, then you have the product users, primary being insulators and brake repair and para-occupational bystanders. Again, this is an inhalational issue. So if you're nearby somebody breathing the same air as they are, they may be protected. However, if you're standing next to them with a different job category, you're not necessarily protected. And then as we get down, larger and larger numbers who are in the maintenance sort of activities where these products have been installed, and then household contacts, as well as consumer products and other things. So the problem is, as we go down the triangle, the number of individuals increases, exposures tend to be somewhat less, and it becomes more problematic to try to differentiate what kind of disease is occurring in the group. From an environmental public health standpoint, there's critical keys to the future of how do we gather this kind of information. Right now, we're in an informational decade where we can link large databases. For those of you who know medical records things, you have EPIC systems, which is headquartered just outside of Madison, who have, after much pressure, allowed individuals to analyze all their medical data that they've gathered on individuals. And you have these humongous size databases that can be mined for information. Of course, it's only as good as what's been recorded in the data systems. And I'll show some of that information, not from them, but from earlier work. We've heard about this, and I just would remind you of, look at the one on the right there. After the spraying of the infrastructure in a building, it's kind of, how do you take care of that? How do you remove all of that? And what do you do about it? And of course, you saw from Dick, took quite a while. We recognized this was a hazardous circumstance, not just for the workers, but everybody then within the building. Buildings tend to be renovated as you go, and it becomes problematic. So one of the things is you now have a lot of people working in those buildings who are maintaining them, who are remodeling them. Again, as we go from older buildings, like in University of Wisconsin, we now have to have all of these buildings wired for computers, all of the old buildings. And if it was sprayed, you all typically have a suspended ceiling. And how do you suspend that ceiling? You have to scrape off what's covering it to make the anchors you put in hold the ceiling up. And so you have a whole nother workforce that one may be doing repairs or maybe installing these, but they're really not trained. They just know this is going to fall down if I can't screw it on tight. So you scrape everything off. And then as you have trucks go by outside the building, people moving around, every time the HVAC starts up, there's vibration, and gradually things fall down on top of the suspended ceiling. The issue is nobody sees that. So in a building where you're, like in a lot of the schools, you have a problem with deferred maintenance. So this is going on. The workers that do wiring and go up to take care of leaks and things like that go above the ceilings, and they see all of the stuff that's fallen down, but there's just a fine dust may come down, and some of the teachers may then complain that, geez, I got to dust my desk all the time, everything, all my books are all covered with this fine powder, and that's, nobody realizes what kind of exposures are occurring. So I'm going to give you a lot of really old data. Typically, when us scientists come and present, we want to have the latest information, all things that are new. I'm going to go back to some of the early work that I did, and you can see this is looking at mesotheliomas in Wisconsin from 1959 to 89. That really wasn't in an electronic data system. We had the records, and so we looked at all of the death certificates, and what happens over the years has been that all of that then gets coded. So you got a different set of employees that look at the words and say, oh, geez, what's that? What's a mesothelioma? Well, that's a cancer. So you go into the cancers. Say, well, where is it? Or in the lungs. So a lot of early mesotheliomas got coded as lung cancer. If you look at the death certificate, it may describe something more, but those words are lost. So that now we're getting into the electronics and the data systems that can auto-code a lot of things. So one of the big issues that I fought for many years in Wisconsin was on the death certificates listed occupation and industry. Typically, as you went through it, it was expensive to get that coded. And if you think as COVID, when it came around, getting the record systems to put in what kind of work with individuals who were developing COVID, what they did, there were only three or four codes. One is it a healthcare worker? Was it a response individual? But all the other industries, such as the pork industry and workers in various facilities and chicken cleaning and things like that, those didn't get coded right away. So we really didn't recognize what were the risk factors for a lot of these things. But as you can see here, this is just one of our tables that we did, and you got a little stars there. You'll see the maintenance workers there. There were 33 males and 1 female death between 59 and 89. And then we singled out that there were school maintenance workers, of which we had 11. So when you think of the spraying of the buildings and the workers that are in there, these are maintenance workers who were going above, so it made sense that they would have been exposed. And there's a lot of buildings that have been sprayed or were using insulation materials that the workers would come into contact with. And then again, for those of you who went to some of these schools and you go into the gymnasium, they would have a sprayed ceiling, and you wonder, why are these all little pockmarks up there? What do the students do? You want to, if you're tall, you jump up and you punch your name into this soft asbestos, or you hit tennis balls up there and everybody stands around and laughs, except for the maintenance workers who come along and they have to clean it up, brush it all up. So what's been seen in issues in those schools are the maintenance. And so we had schools that we were concerned about. Then you see down here, we have 13 teachers who developed disease. Well, for those in the legal business, you'd say there's lots of things that teachers do if they don't work all year, so they may have had a construction job or something, and they weren't exposed at the school. So you go back and you interview these individuals, and this is one of the first papers we did to look at to say, did they ever have any other identified source of exposure to asbestos? So you can see relatively small numbers. You can see shipyard workers, the top of the pyramid, and the asbestos insulators. We had only 7 deaths in that period of time. So then you may, for those of you who are around, there's the AHERA regulations that required all schools to be inspected for asbestos. They created whether it was friable asbestos, whether it was in poor repair, and as you see above the ceilings. And of course, my program was in charge of pulling that data together and looking at it. All of the buildings were expected, they had to have a plan of how they were going to manage this. And you might ask, so what's happened to that? This is data from 1989. That's 35 years ago. Most of those buildings are still there. And they're all new workers. Different workers have been there. So the problem is we begin these programs, you gather great data, everybody assumes problem solved. And that's a major problem as we go through. You can see also the differences between the public schools and our private school districts. You can see the private schools who tended to have more funds to handle maintenance and take care of this and do removals tended to be a little newer buildings than the old buildings. But you can see here on thermal insulation surfacing materials, 17% or 19% had friable surfacing material in the public schools versus 12% in the private. And you can see here quite a difference between the two, but all of them had problems that they then had to have a plan in place. So now this is additional information on cause of death on national death certificates. And this again is older data from 1990 to 1999. And here you can see 842 CIC code, elementary and secondary schools. There you have 53 asbestosis deaths amongst individuals in schools. Now, this isn't broken out nationally because of the coding. This would include some maintenance workers and others in the school. But again, it's kind of a alarm signal that maybe there's something going on that we ought to be looking into. But again, there's lots of information nationally, and this is asbestosis. So our most recent work we published 3 years after I retired, got the staff to pull it all together and do some fairly sophisticated analyses on it. And here you can see where I have the little stars, and I'm going to talk briefly about paper manufacturing. Well, everybody thinks, oh, they must be making asbestos paper. No. So I'll talk a little bit about the issue there. But here you can see 59 cases there of paper manufacturing industry. And then as you go down, you'll see primary, secondary, special education. Now the numbers from 13 is up to 49. Now, of course, the first was the first 30 years in Wisconsin. And now we move on further up. And so there's considerably more cases have occurred. So this is not an issue that's going away. So you heard about sentinel cases, and one of the kind of fun things that public health does is I was in charge of a state with 6.3 million people. And frequently people will talk about, a risk of 1 in a million. Well, 1 in a million in Wisconsin is 6 individuals every year, 1 in a million sorts of things. So you have an opportunity to have rare events occur and then look into them. Typically, that as a start, and again, we heard briefly about vinyl chloride, that began with some physicians seeing 3 unusual cases of a cancer, which they then reported on, and that led to further investigation. So that's one of the things in public health is you have these opportunities to do case reports and look at things. Same kind of thing began recently in the manufactured silica product for countertops and things. It's manufactured handmade stone that workers developed acute silicosis. And that, again, was individual cases being found. In Wisconsin, they came to light first through young transplant patients in the hospital. But again, when I first came to Wisconsin, pneumoconiosis was an issue, and there were very few certified individual physicians in the state, so we began a consultation program. It's very challenging to get doctors to report. Nobody wants to report to the government because that'll result in somebody investigating what you did and looking into it. So we provided a service to the physicians to say, if you see somebody that has chest x-ray abnormalities that appear to be fibrosis, don't just say fibrosis, ask them what they do for a living, and if you think it might be asbestosis or silicosis, send the x-rays, we'll give you a free reading. And oh, by the way, if you want a free interpretation, consultation, here's a form you have to fill out that gives a good occupational history on the individuals. So we began providing that service in the state. We began in 1985, and by the time I left, we'd received 5,200 x-rays to provide advice on and help with. And in April of '86, we had a painter from a paper mill with asbestosis. And then the subsequent year, we had an electrician from the same paper mill that came in. And we said, oh, gee, that's curious. We've been to look at the literature. And yeah, there were other cases of things happening in paper mills. And Wisconsin is a big paper manufacturing state. And so we went to the company and we said, you may have a problem. We knew the doctors that had reported this to us, worked with the paper mill. We then looked through our data systems and we found that there were mesotheliomas that had paper manufacturing jobs as well. You can see here beginning in 65 to 69 and going up to 1989, the numbers of mesotheliomas that are occurring. And you might say, what were the changes that all of a sudden led to big spike in the number of mesotheliomas? Well, cost savings in many of the paper mills was the faster you can have the paper come out, the easier or the less costly it is to manufacture. So to make paper come out fast, they have to dry the paper faster. So they put in big ovens. So as the paper came out to go on the big rolls that you've seen, it would go through a dryer. And of course, the dryer had an increased heat over the time, so the paper could go by very quickly. And it turned out that they had purchased dryers to add to their paper rolling machines. And it was a metal sandwich about 6 inches, 4 to 5 inches thick that went over it, and it was all packed with asbestos. So then, because the machines are vibrating continuously as the paper comes out, there would be fine dust from the paper as well as other dust, and they would blow off these heating elements or the covers of it with air hoses to get the dust out of them. And we identified that as asbestos, which nobody knew about in the plant. They had just purchased these. And so we identified what probably was the contribution to it, worked with the company. You can see on the right side, they said, well, we're concerned. And so we helped them do a little radiographic survey, and then we moved on from that. So there's been all sorts of literature and analyses on household and other types of exposures. And you'll see here, this is from data out of 2000, just 25 years ago. A lot of literature that was then summarized with doing meta-analyses. And you can see coming up with an excess risk from household exposure to asbestos, neighborhood exposure. And unfortunately, most of these, if not all of the studies, are from European countries, Australia, because the U.S. really doesn't have adequate surveillance for mesothelioma and other sorts of issues. There's no registries. So current responsibilities, identifying disease and exposure, preventive measures we've heard about, and then the remedies for what's found. You have enforcement and compensation to individuals. And then part of the issue is safeguards for the future, and that's what the legal issues that are going on now as it relates to EPA and a ban on asbestos coming in is very important. We have a moral responsibility. One is you have scientists generating a lot of data. They publish it, but it tends not to be seen by the people who really need to know. And then we need a translation, the scientific knowledge, into industrial practice and then regulation and control. This reminds me of this cartoon, which is we generate the data over there, we store it over here, and nobody knows about it, nobody sees it. So part of what's the responsibility of this organization has been to track down that information and get it out so that people know about it and can act. Lastly, I would like to end with a memory from when I first went to medical school. Typically, doctors are first, you diagnose and you treat. That's downstream sorts of issues. Prevention issues, on the other hand, are upstream, which typically you don't hear much about. Wisconsin was very prevention-oriented. So in our Introduction to Medicine course, we had a number of books, and one of them was by René Dubois, who got the Pulitzer Prize in '69, who basically, and he's the one that said, I think it's think globally and but act locally. He's attributed with that phrase that we frequently use. And as you can read from this, the issue is that yes, treatment is important, and that, but really if we're healthier, because we've got a healthier environment that we take care of. Thank you.
At Mount Sinai School of Medicine, she's director of the mesothelioma program. She was trained at Harvard. And she subsequently trained in thoracic surgery at Brigham and Women's, really the premier place for training. And she's really a leader in thoracic surgery for mesothelioma, and also a public health person, public health leader. So welcome.
Thank you. Thank you to Linda and Ellen and really everyone here on the panel and attending the meeting. I'm delighted to be here. I always start with the disclosure that I'm from Mount Sinai, like a lot of the folks here, and that is where Irving Selikoff first described the relationship between asbestos and cancer. So I say that with a great deal of pride. It is one of the reasons I came to work there. Likewise, to work with my partner Raja Flores, who is also an expert in mesothelioma, and it's something I've been passionate about now for about 16 or 17 years. So here's a little roadmap of what I'm going to discuss. I can't thank Linda enough. She asked me to talk about something that's very near and dear to me, and that's the early detection, diagnosis, and treatment of patients with mesothelioma and asbestos-related diseases. And so we'll talk a little bit about early detection through screening, the diagnosis in a symptomatic patient, and a little more about something that I focus a lot on, the treatment of pleural mesothelioma, the most dreaded asbestos-related disease, as we've described. So early detection is accomplished through screening. The screening in a high risk, mostly in high risk patients, but screening is a test you do to look for disease in somebody without symptoms. The most common example is the yearly mammogram women undergo to screen for breast cancer. Now, ideally, screening can accomplish early detection, and early detection would lead to an early diagnosis. Unfortunately, we see all too often that's not the case with diseases like pleural mesothelioma. to clarify the distinction, a diagnostic test is something that's done in somebody who has symptoms, looking for a disease. For example, this is a patient of mine who had shortness of breath and underwent an x-ray that was abnormal, leading to a chest CT that showed fluid between his lung and his rib cage. But this process, as many of the folks here can tell you, took 8 months to get to this point. And we hear that quite frequently. And one of the great powers of the group and of Linda and her work with ADAO is to share these stories. And I really just want to take a moment to thank Linda and Emily and Marilyn and her children and Alice and Rachel for sharing these stories. This is not only carrying on the legacy of Alan and Joe and Gilbert and many, many others, but it's also becoming the world expert in the exposure and what to do about it, how to try to stop these exposures, to change the future, and educating medical students and residents, fellows, doctors, public health officials, Congress, and people who can take action. And that's how this world is going to change. But man, 20 years, it's a slow process. So the problem with a lot of the asbestos-related diseases, and mesothelioma in particular, is that there is really no good screening test. We heard a little bit from Chris about the power of the low-dose chest CT to screen for lung cancer and the documented reduction in mortality related to lung cancer. But we don't have that equivalent in mesothelioma. And a baseline low-dose chest CT can help, and breathing function tests can help, but we're just not there yet. The key is regular medical care, staying informed, and the patients and families expressing and talking about their symptoms. We hear stories repeatedly of people, especially high-functioning and athletic people, just sort of, oh, it'll be fine. My my cough will clear up, or that shortness of breath, I'm just having a bad day, and people walk around like this for months. But we want them to speak up, and what you're doing is helping others speak up so that they can identify this earlier. But clinicians need to have a high index of suspicion. Very often we hear stories of primary care doctors or even specialists just saying, well, this comes with age. When a patient experiences a change in their function, that's not normal. And the idea is not to invoke fear in patients or people exposed, but really to empower them to get ahead of this, because early diagnosis is key. And this really, pleural mesothelioma in particular, is a disease that we have trouble diagnosing early. Early diagnosis is the key to survival. The key to early diagnosis, however, is the informed patient and the informed clinician. And the work that you are all doing is helping to inform clinicians and helping to inform patients. The power are in the patients themselves and their caregivers, and we need to disseminate this. And so we need to teach our students to continue to do a good history and physical. It's sort of a lost art in medical school these days. My brother is a very young surgeon. He's a resident, and he said, well, why should I do this exam or this particular aspect? We're just going to get this test anyway. There are clues that we pick up on, and Linda's the one who taught me about the importance of a good occupational exposure history, we talk to these teachers, well, what did you do in the summer, or what exactly went on in that building? And that is really important in terms of estimating risk and having a high index of suspicion. And again, we want to stamp out the fear, but we want to keep people at attention and not ignoring things. So I'm going to really focus on the treatment of pleural mesothelioma because that's what I'm truly passionate about, and I think others are better experts in the exposure and some of what has been discussed and very informative. So there really hasn't been that much progress. We talked about IMIG, and unfortunately, there are a lot of exciting things that are coming together, and our understanding is improving, but the actual success of this has not improved markedly. But one thing we've learned in the last 50 years is that more than one treatment strategy is necessary. People have to undergo multimodality therapy, and I'll talk about what that involves. But generally, that may include surgery, radiation, chemotherapy. One of the newer drugs to hit the market, or many of the newer drugs to hit the market, are immunotherapy that you hear a lot about. But there are also other targeted therapies and CAR T cells and vaccine therapies, and we are slowly making progress. But the key is more than one therapy, and to find experts and to find centers of excellence. I run the New York Mesothelioma program. It's a multidisciplinary program that involves an expert medical oncologist in mesothelioma, the world expert in radiation oncology for mesothelioma, Ken Rosenzweig, an oncogeneralist, cardio-oncologist, palliative care specialist, social workers, and a whole team. I'm blessed and thankful to have an excellent team, not only of multidisciplinary care providers, but also perioperative care nurses and ICUs and people to help take care of these patients, which is something I'll focus on next. Because the treatment for pleural mesothelioma is very difficult. It's not easy. I'm a surgeon, so I'm biased, and we'll discuss surgery. And this is a sort of a controversial issue, as within the last 6 months, there was a randomized controlled trial published that claimed that the surgery done for mesothelioma does not improve survival, and we'll discuss that. But the first surgery that was done for pleural mesothelioma was extrapleural pneumonectomy, and that's the removal of the lung, the pleura where the tumor is, but also the diaphragm, the muscle that separates the chest from the abdomen, and the pericardium, the sac around the heart. The British published the first series almost 50 years ago, and had 1 out of 3 patients die. 31% mortality. And even the authors said most of them could have been prevented. 45% of patients had complications. This is, it may be hard to see, but this is what it looks like. An extrapleural pneumonectomy sort of exenterates the chest, and this is what the chest looks like. The heart and the aorta remain, but that's about it. And this is what the specimen looks like. That's my little hand and a big lung with pleura, diaphragm, and pericardium attached next. Now, the British tried to assess this operation about 20 years ago in a trial called MARS. And it was looked at extrapleural pneumonectomy versus no extrapleural pneumonectomy in patients with pleural mesothelioma. And they actually failed to randomize, but drew the conclusion that this was not an operation that benefited patients in terms of survival. But at the same time, many of us were already finding that. My partner published a study in 2009 demonstrated no difference in survival with the extrapleural pneumonectomy compared to a lesser operation called the pleurectomy decortication. When I say lesser, I just mean less morbid, less taxing on the patient. And that's where the pleura and tumor are removed, but the lung is preserved. Next slide. And these are just several of many successive studies performed showing that the pleurectomy decortication was not only just as good in terms of survival, but also better tolerated and had a far lower mortality or risk of death. This is what the resection looks like after the pleura and the tumor are removed. You sort of have this raw lung and chest. This is what the specimen looks like. Next slide. So to the credit of the British, they tried to randomize patients to the pleurectomy decortication. They gave them 2 cycles of chemotherapy. A complete course of chemotherapy is generally considered 4 to 6 cycles. So they gave patients 2 cycles of chemotherapy and then randomized them either to have the pleurectomy decortication or to go on to have more chemotherapy. Next. What they found was no difference in overall survival between the 2 groups. But the 30-day and in-hospital mortality for people with surgery was 4%. The 90-day mortality was 9%. So almost 1 out of 10 of their patients died within 3 months. And the median length of stay was about 2 weeks or 13 days. And the physical function and quality of life of these patients was significantly worse in the surgery group, although it sort of came together after 6 weeks and improved. This is a meta-analysis I published with co-authors at Mount Sinai looking at all published papers on pleurectomy decortication compared to extrapleural pneumonectomy, and the mortality for pleurectomy decortication should be about 2%. not 4%, and certainly not 9%. And it was pretty consistent across all studies reported, which led to the question, what are they doing? Or what were they doing? And I know the surgeons involved, they're good surgeons, but let's look a little closer next. This is just highlighting that the patients were early stage patients. The T1, T2 reflect how much tumor they had by our staging system, and over 53% of these patients had early stage disease, but 90% of them had their diaphragm or pericardium removed. So they were having this very big operation, and in fact, the authors report getting all microscopic disease in 3% of cases, and most of us in this field for the last 15 years have acknowledged that we can't ever get all the microscopic margins negative, and the pathologists who look at this tissue can't even tell. So there's some kind of there's something strange about this, but more importantly, they're opening the cavity to the heart and to the abdomen in over 90% of people with early stage disease, exposing them for progression. And what this shows is that people in the surgery arm did not finish chemotherapy after that. First of all, almost 9 or 10% of them died, so they couldn't go on. But even those who did not. And any additional treatment, far fewer people in the surgery arm went on to have additional therapy. And we know that mesothelioma requires multiple therapies. So the real lesson is that patients who had half a course of chemotherapy undergoing a massive operation with a 2-week hospital stay where 9% of them died did not benefit from surgery. But many of us already knew that and believed that the operation should be catered to the patient, personalized to the patient, and needs to be done carefully so that the patient can live to fight another day, because additional treatments are needed. And it requires a multidisciplinary care team, including medical radiation oncologists and surgeons. This is a clinical trial that I just completed, where 20 patients in this pilot study underwent a vaccine and 2 to 4 weeks later had pleurectomy decortication. And the average hospital stay for these patients was 6 days, and the 90-day mortality was 0. No one died. This is just the schema for the trial. Now we're seeing some exciting responses. This is the same patient on the left and the right, and after treatment, you can see the kind of areas that light up are now gone. And in fact, this patient had a liver metastasis that actually disappeared as well after treatment. So the conclusions, or what I want to summarize and drive home, is that we as treating physicians as surgeons need to do the right operation in the right patient at the right center. And I'm not being critical of surgeons, I'm describing the whole team, that the ICU, the nurses, the radiation and medical oncologists, pulmonologists, the radiologists and pathologists have to be experienced and be able to take care of the patient. And that if patients are going to be given chemotherapy, you have to help them finish it, because multimodality therapy is needed, and that's what improves survival. So I don't want to instill fear. I want to continue the tradition of Linda, the ADAO, and the others here to help keep people informed, that we fight together. And for as long as a patient feels well, they are well, and that we will fight with you so that you can live to fight another day. And thank you. This is my team at Mount Sinai.
Jackie was trained at Mount Sinai. She actually directed the Educational Resource Center. She directed the World Trade Center Health Program at Sinai for many years, and that's especially notable this time of year, around September 11th. And then she moved to Northwell, where she founded the Department of Occupational Medicine Epidemiology, which she's been in charge of for a dozen or so years. And in addition, does on the side some research in asbestos-related disease. So welcome, Jackie.
Hi, good morning. It's a pleasure to be here, and we're going to talk a little bit about legacy and some other places you can find asbestos. So I'm going to skip through a lot of these, or I'm just going to let you read them because my colleagues have already covered it. But asbestos is found in a number of old buildings, but it's also found in a number of different materials, many of which are well known, like brakes and construction materials. But we'll talk about some that aren't as well known. So there's 6 basic types. You can't see it, you can't taste it, you can't feel it. People played with it. They threw snowballs because it didn't affect their skin. The only way to really tell is to test it. And you have to test it in a way that you can find it. You can't test it in a way that's below. There's something called a limit of detection. And if you set a limit of detection at a certain point that isn't sensitive enough to find it, you can say there's no asbestos, but what they're really not saying, what they're saying is they can't find it at that level of detection. They're not saying there's no asbestos there. They just don't have a method that's sensitive enough to find it. So we know that asbestos has been linked to talc in cosmetics and other uses of industrial talc. And in other products, it's been found in crayons, for example. So here's just some pictures. You can see why, as Chris said, it was amosite is brown asbestos because it looks brown. Chrysotolite was called blue asbestos because it appears more blue. And chrysotile is called white asbestos. And then the others are usually found, anthophyllite is found in Finland as the primary fiber there. And the others are often found in conjunction with some of the other commercial brands, which are the top 3. So legacy asbestos, we talked about it a little bit, and Andy talked about it in buildings with teachers. It refers to asbestos fibers that are embedded in buildings infrastructures around the U.S., actually around the world. The U.S. Senate in 2015 found that most states aren't systematically monitoring. I was doing some work with the Health and Safety Committee of the United Federation of Teachers, the teachers union in New York. And in 1996, we were overwhelmed by Operation Clean House, which was what they called the asbestos, where they actually had to go and catalog according to HERA, which had already been passed. But we went into a number of schools where they cataloged where the asbestos was, and they did a huge remediation over the summer in 1996 for many of there are over 1,000 New York City schools. So as we talked about, it's in old buildings, and these exposures can cause serious illnesses when they're disturbed by fire, extreme weathers, and again, a lot of this was covered earlier. So there are legacy asbestos. We heard from the Duran family where Mr. Duran worked with cement pipes for a large part of his early career. And we know there's insulation on pipes and boilers that may still remain. I actually saw some patients a couple of weeks ago who were boiler makers, and they were exposed to asbestos when they were doing some boiler clean out and removal of an older boiler. So even in 2024, we're still seeing patients that are exposed to asbestos, and they realized they were exposed to asbestos. Luckily, the project supervisor had been trained, and he said, we're out of here, and he actually took a sample and had it tested. In attic and wall insulation, many buildings have vermiculite as poured in from that contains some of the Libby amphibole, siding and roofing materials, and children's toys. So there's here's some graphics on it. Toasters used to have asbestos. Some before the Consumer Product Safety banned it was used in some hair dryers. Vinyl wallpaper. I mean, there's all sorts of places that when paint actually has industrial talc in it. And if you look at the, I think it's Nital is a brand, one of the large paint companies used tons and tons of industrial talc in the formulation of their paints. And actually some of the textures on the outside paints actually were very heavy in the amount of industrial talc. And it's not something you think about also because we think of paint as a liquid. And if you can't breathe in a liquid, but when you're making it, you can, and then there's opportunities for exposure. So you can see lots of duct adhesives are used in floor tile mastic, which is the stuff that makes the floor tiles sticky, in acoustical panels. These are too recent, so don't worry about this ceiling. And in a number of other places, asbestos mittens or gloves, they were used as the shields in Bunsen burners. So consumer products, there have been a number of products. I talked about a few of them, and they were in the early 1900s to 1980s. And this really exposed folks from all walks of life. And we're thinking consumer products as things that you would encounter as a consumer, not just as someone in the construction field. For example, there are people who were remodeling their houses, and so they wanted to make the ceilings look pretty. So they would do swirls of joint compound. So they'd mix up the dry joint compound with some water, and then they would make their little swirls, except that the joint compound had a lot of asbestos in it. So they didn't realize that by decorating their house themselves, they were exposing themselves. So other children's toys like modeling clay and crayons. We know that modeling clay, again, has the industrial talc in it, and so does ceramics. So people who made, it's called the slip or the green in making pottery. And then often when it comes out of the mold, it's actually shaved so that there's an opportunity for exposure even after it's been mixed. And other objects, the infamous Kent micronite filters from 1952 to 1956 had chrysotolite, oven mitts, bottle warmers, sports and other recreational equipment. So rubber, I remember there was a study that was looking actually at brake linings and brake workers in Connecticut, and they found that there were a host of people who were in the rubber industry who had mesothelioma. And I said, why would people working with rubber, which is a different product that has its own host of issues, have mesothelioma? And it turns out that when you're making tires, to make them not stick, they're dusted in talc. So they all had this talc exposure when they were working, and that was the exposure. And it's also used as a component in the molds to help get the rubber out. So there's bags and bags, tons of it used in the rubber industry. And then we found it's in cosmetic talc, and it's been in talcum powder, face and body powders. So talc is a mineral crushed into a powder, absorbs moisture, oil, odor, and is a lubricant, why it was used in tires. It's used in a number of cosmetics, some of which it's bound, and some of it is loose. It's also used in food processing. It's actually put into pills and things like that. Chewing gum, insecticides, polished rice. I don't know if it's still being used for this, but historically it was. So talc and asbestos are minerals found close together. They grow geologically and in a similar habitat or a habit. And but often the talc, because it's sort of a transition from talc to fibrous talc to asbestos, it's a continuum. And so the asbestos goes with the talc. So one geologist has said, I don't like the term asbestos contaminated talc. He said, because it's not contaminating it, it just is. So it's asbestos and talc together. So it's not so much as contaminant, because that seems like it's been added. It's just the natural product. So we see talc, it absorbs moisture, reduces skin, found in powder compacts, finishing powder, eyeshadows, blushes, foundations, and creams. The creams you don't worry about so much because it gets bound up. But when it's in loose powders, or even you can see that palette there is pressed powder. So people will do weird things where they'll scrape it with their nail when it's in a pressed powder so that it more readily flows. People do interesting things with makeup. So the 2019, the FDA, which does not regulate talc, but found asbestos in nearly 20% of 52 cosmetic samples. Products included the ones listed there, and a study in 2020 revealed 14% of cosmetic products contained talc, also showed asbestos traces. So if you use sensitive enough techniques, you will find it. There are techniques that were published in the 90s that show that you can concentrate whatever fibers are there and find the amphiboles. It doesn't show the chrysotile that's there because of the different weighting in these very specialized techniques, but there are other ways of looking at that. But the bottom line is it became much more in the public's eye, that people were aware that cosmetic talc could potentially cause asbestos related diseases, including mesothelioma. So this is just Claire's products. They found this was actually one of the first times that it really made the press. Although in the 1970s, there were a lot of articles about cosmetics found in talc, asbestos found in talc actually from Mount Sinai in the 1970s. So here's just some test results that came from Claire's where they found asbestos in it. And it was really disconcerting because these were marketed to preteens. So here you can just see where they found it and the type of asbestos, I think, is on there, or the percentage. And again, here's some other products that showed that asbestos was present. Again, additional, and this led to a recall of one of the products in 2019. The most popular brand of baby powder was recalled from this batch after it was found to be tested. So the future considerations, we're going to be exploring this a lot more later about EPS ban chrysotile in 6 conditions. I think Andrea alluded to it in terms of taking the history. And one of the things that I've been talking about and why I think Andy was talking about the differential, or maybe Chris was talking about the differential between men and women. How many of you have ever had a really good occupational history taken when you went to the doctor? They ask, what did you do? Just raise your hand if you've ever, how many of you have been asked what you did when you went to the doctor? That one I expect everyone to be. Someone will say, what do you do? How many of you have actually asked what you did, not what your job title was? Okay. Now, how many of you have ever been asked what kind of consumer products you use in your home? So none of you have. So when we look at these studies that talk about it, and some of the studies on women are god awful. If they didn't fit the criteria that they were asking the men of the 9 most common professions where asbestos was used, if the women weren't a part of that profession, then they had no exposure. They didn't ask if there were family members of those who did that even, but it was just, but no one ever asks about certain exposures. So if you don't ask, you're never going to know. Doctors don't realize that there are things like asbestos containing consumer products, whether it be paint or whether it be talcum powder. So no one's ever going to really know what the source of it was. I think over time we've had the ability from some of our colleagues in the legal field who have probed those questions when they've gotten people who have not fit a traditional asbestos worker mold, where we've learned much more about it and we've been able to define some of the exposures that may be pertinent and get the word out so that people will know to how to protect their health in the future. And that would become the primary prevention so that we have to do a lot less CT scans for that tertiary prevention. Thank you.
Hi, Dr. Oliver. I'm Marty Ditkoff. I just did a thesis, coincidentally, one of your papers or one of your, a letter you had sent to the EPA was cited, and you were discussing why kids were much more vulnerable for inhalation of asbestos. And if I remember correctly, your letter said not just because their age differentiation, but that the way the lungs are developed when they're young actually gives them a higher level of exposure. Did I remember that right? And if so, do you still believe that?
I think I haven't researched this recently, so I'm not sure if additional data have come out, but I think there are 2 other alleged contributing factors. They're not alleged. Respiratory rate. Kids have a higher respiratory rate. And so given X amount of asbestos fibers in the air, they're going to breathe in more. Their bodies are smaller. But on the other hand, their respiratory rate is greater. I don't know of anything specifically about the physiology of the lungs of children versus adults that would play a role here. The other thing that's been mentioned is that they're shorter. And so if you if you have asbestos fibers that are settling, then or they're being entrained, then their exposures might be higher because they're closer to their breathing zone is closer to where the fibers are. So I think I mentioned each of those, and to my knowledge that hasn't changed.
Thank you. Other questions?
I have a quick one. Medically speaking, are you seeing any work done on the psychosocial part of a patient and the family? Because mental health for mesothelioma patients is brutal for both patient and family, as you heard from the Duran family. Are you seeing studies at Mount Sinai or Dr. Moline elsewhere? Because that's a component that ADAO is very passionate about, is a holistic approach like you offer at Mount Sinai.
Thanks for the question about the mental health aspects. Very poignant stories and very informative in educating us providers. Yes, we're looking specifically at quality of life, certainly of the patients, but I agree with the point that extends to the family and the care providers, because these experiences really are horrific, and in order to get through this, we need to look at that. So yes, there are studies on quality of life, but we haven't yet explored the mental health of the care providers, and I think that's a very, very important point that we should, and something that we can look at. And our group is looking at quality of life, so we will extend that. Thanks for the suggestion.
There are a number of, at a lot of the cancer institutes, there are support groups for families. We actually started one in the World Trade Center. It's a program that I run actually specifically for prostate cancer survivors because they have unique concerns, and also their family members, because it does affect the whole family. But I think there is a greater need to ensure that as we're providing care for the patients, and I would say from looking at medical records from all over the country, for the most part, the mental health needs of the patient are addressed. Very rarely is there enough emphasis on the impact of who the caretakers are. And that's something that hopefully will change as there is more of a recognition of the importance for the optimum care of the patient and the aftermath for the family.
I have a related question, then we'll get to Dick, which is, I had programs like Sinai, Brigham and Women's centers, UPenn, give terrific care, and the care options are limited. People don't necessarily do all that well in the longer term, but they get great care. But I do worry about the people in New York from Watertown, way upstate, or from Plattsburgh, or from distant parts of the state, whichever state. So my question for Andrea is, you run a great program. How, and this is actually frankly for the attorneys in the room as well. Like, how can we increase the availability for patients who are diagnosed with mesothelioma in rural areas or places far away from the centers?
Also a great point, and thanks for that question, Stephen. I think through work like the ADAO is doing, and through education and dissemination and being vocal and turning and including patients, families, and caretakers to help educate. The key thing I've worked on for the last 16 years is helping to reduce the nihilism in this disease, because all too often, and yes, it's a very difficult disease to fight, and it's a difficult battle, but to make a diagnosis and turn to the patient and say there's nothing we can do, get your things in order, you're going to die in 6 months, it is not helpful, and many times it's not the case. And so I think through the education and increased awareness, that will help clinicians and patients find centers and find the appropriate care. Sort of one of the silver lining outcomes of the pandemic has been the increased use of virtual resources and the availability of sort of virtual consultations and the improved communication among people specializing in this disease and extending to help do that outreach. I have found over the last 5 years an increased number of referrals from outside, many of whom who may not ultimately get care at a tertiary center, but who at least get opinions, consultations, and informed and help inform their treating clinicians from tertiary centers. And so I want to keep emphasizing the importance of arm yourself with information, get information, ask questions, and don't be intimidated. So I think that's progress, but a long ways to go.
Okay, thank you. Dick, you have a question?
I just have a comment. Back in the early 1970s, one of the first epidemiological studies that we did at the National Institute for Occupational Safety and Health of a plant in Mannheim, Pennsylvania, we found a very interesting finding in that plant, and that was we had a significantly excess amount of suicides. And Dr. Selikoff used to mention the asbestotics and asbestos patients going upstairs backwards because they would sit down every other step to gain breath. We went back and looked at the suicide cases, and a lot of them had existing asbestos-related disease. So I just wanted to make you aware of that study. We actually published it in the Federal Register. It was introduced into the Senate, and I haven't seen many studies like that since that study was published. That's almost 50 years ago. That's all.
Yeah, other questions or comments? Otherwise, we'll close this session. Quick comment from Arthur.
Yeah, Dick, I have, in my looking at files and such, have seen any number of cases of suicide in patients with mesothelioma and have looked at the more recent literature. And there is actually a literature out there on generally suicide in patients with significant disease like cancer, but mesothelioma is one that comes up specifically, along with pancreatic often is mentioned as well, but that's been looked at.